Hello everyone, and welcome to today's very important lecture on ischemic heart disease. Hopefully by the end of this, I'll be able to simplify what can sometimes be a very confusing topic. My objectives for this lecture are first, for you to be able to understand the pathophysiology of coronary ischemia, to understand the definition of a myocardial infarction and understand its individual components, to recognize concerning EKG patterns that would warrant urgent intervention, to learn how to classify and risk stratify your patients who present with chest pain, to learn the role of stress testing in stratifying those patients with chest pain and knowing which stress test to order for a given patient, to order appropriate testing and prescribe evidence-based medical therapy for patients with ischemic heart diseases, to understand the importance of early intervention strategies in managing acute myocardial infarction, to understand percutaneous intervention, or PCI, and the role of stenting, to understand the indications for coronary artery bypass surgery, or CABG, and how it's performed, and to recognize and manage the common complications that accompany an MI. Starting off with understanding the concepts of ischemia and infarction, cardiac ischemia is essentially when the blood supply to the heart is inadequate to meet the demands of the heart, and that leads to cellular injury. On the other hand, an infarction occurs when cardiac muscle actually dies as a result of having inadequate blood supply. So it's essentially a supply and demand mismatch issue. So breaking this concept of supply and demand further, inadequate supply to the heart can be due to growing atherosclerotic plaque from elevated cholesterol levels, platelet aggregation on top of an existing plaque, an acute plaque rupture event, which is one of the most serious complications that would affect supply, a coronary artery dissection, coronary vasospasm, which is what you'll see in what's called Prinzmetal angina, a state of shock where the patient is hypotensive and therefore cannot deliver blood to most of the organs in the body, and aortic stenosis, where the actual calcification of the valve and decrease in diastolic blood pressure leads to decreased blood supply to the heart. On the other hand, increased cardiac demand can be due to infection or sepsis, which is very common in our patients, severe anemia, where there's not enough hemoglobin to supply the heart, acute hypertension, where the increased afterload from hypertension will actually increase the workload of the heart, acute heart failure, a tachyarrhythmia, such as acute onset of atrial fibrillation with RVR, hyperthyroidism, and pregnancy. Moving on to the types of different ischemic heart disease manifestations, you'll see here on the picture on the top left a normal-looking coronary artery with its tunica intima all the way in the middle of the lumen, surrounded by the muscular media and the fibrous adventitia. And as we get older in age, cholesterol deposits inside the intima of the artery, forming a plaque. And the reserve of the coronary vessels is good enough that even with a small amount of blockage, enough blood can still get to the heart in most states of rest. But as the plaque gets bigger and bigger, the blood supply won't be enough to meet the demands when a patient exercises, and that leads to symptoms of chest pain and shortness of breath with exertion. And that's classical of what we call stable angina. On the other hand, as this plaque forms, it also opens up the possibilities for platelets to form on top of this plaque, and that can worsen the occlusion. And certain times when these platelet aggregates get big enough, it'll lead to a temporary thrombus formation inside the lumen, which can occlude the blood flow significantly enough that the patient's chest pain and shortness of breath symptoms get worse and even occur at rest. And that's what we call unstable angina. Finally, if this plaque were to rupture and expose its contents to the blood that's flowing through, a complete thrombus can form, completely obscuring the entire lumen, and that will lead to infarction and death of myocardial tissue. And that's the most severe manifestation, which would lead to a myocardial infarction. So there is an actual standard definition of a myocardial infarction. That's the fourth universal definition. It's the most updated one. And there's a few components. The first that should be true in all patients is you need to see a rise and or fall of the cardiac troponin, which is an important biomarker, with at least one level of the troponin higher than 99th percentile of the upper limit of normal. The rise and fall component is very important because no single troponin value should be looked at in isolation. You need to see dynamic changes. If you see a stable level of troponin, that's usually pointing to some other pathology. In addition to the troponin, you either need symptoms of either typical chest pain or shortness of breath associated with that change in troponin. ECG changes, such as Q waves or ST elevations, and certain other ECG manifestations that we'll discuss later. Consistent imaging findings, such as a transthoracic echocardiogram showing wall motion abnormalities in a specific location, or a stress test, myocardial perfusion test showing impaired perfusion in a certain localized area of the myocardium. Finally, you could skip straight ahead and do a direct invasive cardiac catheterization and identify a blockage in the arteries themselves. So troponin plus either symptoms, ECG changes, imaging, or directly cardiac catheterization. That's what you need to define something as an MI. We also sometimes refer to different types of MI. So type 1 MI would be classic textbook plaque rupture causing complete occlusion of the blood vessel, and that's one of the most serious types of MI that requires urgent intervention. Type 2 MI is something that we see often on the medical floors and in the ICUs. It occurs as a result of supply-demand mismatch when there's not an acute plaque rupture. So sometimes we talk about the phrase demand ischemia in this situation, and that's could be due to any of the supply and demand problems that we discussed previously, with the exception of an acute plaque rupture event, which would be a type 1 MI. A type 3 MI is not something that we usually see in the hospital. This is someone who usually died outside of the hospital after they had a suspected myocardial infarction and never actually made it in time to get their labs checked. Type 4 and 5 MIs are procedural complications. So type 4 MI is an MI that occurred in the context of a recent percutaneous intervention, or PCI, which we'll talk about later. And type 5 MI is in the context of a recent coronary artery bypass, or CABG. Now, when we discuss the definition of MI, the troponin was a very important part of that. So it's important to understand what we're looking at when we order a troponin. So here's a graph that I'm sure all of you have seen before. It shows how troponin and another biomarker called CABG rise in the hours to days immediately following a myocardial infarction. So troponin is a protein that occurs naturally in cardiac muscle. It forms along with tropomyosin onto the filaments that are responsible for myocardial contraction. And it rises fairly early, within 2 to 3 hours after the MI, and it'll return to baseline depending on whether you're dealing with the isotypes troponin I or the isotype troponin T. Troponin I will return to normal in 7 days, and troponin T returns to normal in about 14 days. In addition to troponin, we also have the option of ordering creatinine kinase, myocardial muscle bone enzyme. This rises a little bit after the troponin, 4 to 6 hours, and it'll also return back to normal earlier, about 1 to 2 days. In addition to those common biomarkers, there's also myoglobin, which is the first biomarker to rise, usually within a couple of hours after the onset of the infarction. And then historically, just for mostly trivia purposes, in the past there were the liver enzyme AST and LDH used as biomarkers for myocardial infarction. Here you see in this picture where troponin is actually located in the muscle. It's associated with this other protein called tropomyosin, and together they accumulate on the actin and normally prevent myosin from binding onto the actin and causing muscle contraction. So whenever we order troponin, we have to remember that not every troponin elevation is necessarily due to an MI. So we need to think about kidney disease, because impaired kidney function will also lead to decreased troponin clearance from the body. Heart failure, pulmonary embolism, in which case the level of the troponin is actually an independent risk factor for how severe the embolism is. Myocarditis, an infection of the myocardium itself. Takotsubo's cardiomyopathy. And it's important to remember that if a second MI is suspected within a week of the first myocardial infarction, the troponin level would still be elevated for that time period. So it would be important to order a CKMB to look for a second peak in the CKMB to confirm that a second infarction actually occurred. Moving on to the really important topic of ECG changes that you should look for whenever a patient presents with chest pain or palpitations or shortness of breath to make you concerned that they might actually have a myocardial infarction. Now, traditionally, we used to talk about, and we still do, talk about MIs as either ST elevation MIs or those not associated with ST elevation, that non-STEMIs. And the reason that we focus on this classification is that whenever you have a non-total occlusion of the coronary vessel, the subendocardial portion of the myocardium is the first to be affected, and when there's a total occlusion of the coronary vessel, the entire myocardium, an entire transmural area is affected. So looking at this picture, you see in both cases, in A and B, there is a red area on the lateral wall of the left ventricle that's indicating an area of ischemia. So remember that the blood vessels, the coronary vessels, sit on the outside of the heart, and so they'll supply the heart from the outside in. So if there's a non-complete blockage of this vessel, the first area to be affected will be the portion of the heart that's farthest away from this vessel, which is the subendocardial area here. And whenever an area of the heart is ischemic, during the immediately, it's slower to depolarize compared to the rest of the heart. So when it's depolarizing, the vectors will point from the surrounding healthy tissue towards that ischemic area, as you see in the picture. And so the net vector in this area will be pointing away from the lead that it's corresponding to, in this case V5 or V6. And so you'll start to see ST depressions in those leads because the vector is pointing away. On the other hand, if you have total occlusion of the blood vessel supplying this area, the entire wall will be affected. And in this case, the vectors from the nearby myocardium that are healthy will be pointing towards that area, and as a net result, the net vector in the leads anatomically corresponding to that area, in this case again V5 and V6, the vector will be towards those leads, and that'll cause a deflection up from baseline, leading to an ST elevation. Before going on, it's important to understand some basics about the coronary anatomy. So here we see a schematic, the aortic arch, and the three cusps of the aortic valve here, here, and here. and 2 of those 3 cusps have a coronary vessel coming out of them. So the left coronary cusp will give off the left main coronary artery, LMCA, which will branch off into the left circumflex, and the LAD, left anterior descending artery. And these will supply the bulk of the anterior and lateral portions of the LV myocardium. On the right side, the right coronary cusp gives off the right coronary artery. Early on in the course of the right coronary artery, it gives off a small vessel which supplies the SA node. And then it continues around to the back of the heart, and in most cases, about 60% of patients, it also gives rise to the posterior descending artery, PDA, which supplies the posterior wall of the heart. And in a smaller minority of patients, the left circumflex will wrap around and actually supply the posterior descending artery. And in these patients, we call them as having a left dominant circulation. Whichever vessel is dominant, whether it's the circumflex or the RCA, it will also give rise to the vessel supplying the AV node. And that anatomy is important to keep in mind because we use ECGs to find an approximate guess of where a blockage might be. And so we can localize groups of leads and associate them with particular walls of the myocardium. So the anterior wall is associated with changes in leads V3 and V4, that's supplied by the LAD, whereas the inferior wall, which is associated with the leads 2, 3, and AVF, can either be supplied by the right coronary artery or the circumflex, depending on which vessel is dominant, whether it's a right or left dominant circulation. So it's important to keep this table in mind. Now, when is an ST elevation a real ST elevation? There's some criteria that help to identify whether the ST elevation you're looking at is worrying enough. To be significant, the ST elevation has to be seen in 2 anatomically similar leads, such as 2, 2, and 3, which would supply the inferior wall. But if you see isolated elevations in AVR and AVF, that's not significant because they're not; those 2 leads are not anatomically associated. You're going to want to see at least 1 millimeter of J-point elevation. That's with standard ECG calibration, 10 millimeters per millivolt, from the TP baseline in all the standard leads, except for V2 and V3. So for V2 or V3, you set a cutoff of 2.5 millimeters in males who are under 40, 2 millimeters in males above 40, and 1.5 in females. If you're doing a posterior EKG, if you're worried about a posterior wall infarct and you do leads V7, 8, and 9, you'll use a 0.5 millimeter cutoff for those leads. Now, the problem with defining myocardial infarctions in terms of ST elevations and non-ST elevations, there's 2. The first one is that not all ST elevations are actually the result of an acute coronary occlusion event. And here's a list of several conditions besides an acute plaque rupture, coronary occlusion that would cause a patient to have ST elevations on their ECG. So let's look at a few of these. In the first picture here, you see ST elevations in leads V1, V2, and V3, but what you also see are really tall peak T waves in those leads. So notice how narrow-based and tall these T waves are. So that's indicating hyperkalemia. And this patient doesn't need to go to the cath lab, they just need to be given calcium and reduce their potassium level as soon as possible. Here's another example where we see a few ST elevations, very small, what's called concave up ST elevations in leads 1 and 2, but let's assume that they're occurring more diffusely. And what you also see are that the PR segment here is a little lower than the TP segment there. So that's a PR depression. So when you think of ST elevations and PR depressions diffusely, that's an example of pericarditis. Here in this picture, we see ST elevations, again in V1, V2, and V3. They have a particular shape to them. They kind of have they come up and then they downslope, and then they lead into a T-wave inversion. So kind of a downsloping ST depression going into T-wave inversion and leads V1, V2, and V3. And that's a pathognomonic feature of Brugada syndrome, which is a sodium channel mutation that can lead to potentially fatal arrhythmias in young, otherwise healthy people. In this next picture, we see wide QRS complexes in all these precordial leads, V1 through V6. They're much wider than the QRS complexes here and here. Whenever we see wide QRS complexes, the first thing to worry about is a bundle branch block. And in this case, we see that the QRS in leads V5 and V6 are positive with almost an R prime pattern in that QRS complex, and a predominantly negative QRS in V1. And that's typical of a left bundle branch block. And you see that it's associated with look like ST elevations predominantly in the leads where the QRS complex is mainly negative, and ST depressions in the leads where the QRS complex is predominantly positive. And that's normal. That's not suggestive of any kind of ischemia. Finally, in this picture, we see ST elevations, slight ST elevations in leads V2 and V1, along with ST depressions in V4, V5, and V6. So is this something to worry about? Well, let's also look at what else is going on. We see really, really tall R waves in V5 and V6, and really, really deep S waves in V1 and V2. And in this case, you see that the S wave in V2 is actually touching the R wave in V3. And these really tall voltages, especially of the R waves in V5 and V6, is highly suggestive of LVH. So in none of these examples, even though they all have ST elevations that could be considered significant, none of them actually have anything that would warrant them to go to the cath lab right away. The other problem is that not every acute coronary event would necessarily present with an ST elevation. Even though they don't have ST elevations, they may still need very urgent catheterization. And these are a list of examples of conditions where you would see those things. Absence of ST elevations despite being a very worrying ECG. First one is just a regular old Q wave, but this Q wave, regardless of which lead it's in, is not a Q wave that you would associate with just normal septal depolarization. It's wider than one little box, or 40 milliseconds, and it's particularly deep compared to the R wave that it's associated with. Probably greater than a quarter of the height of this corresponding R wave. And in that case, it's a pathologic Q wave, which is suggestive of an older infarct. Again, no ST elevation there. The second example, we see, again, no ST elevations, but we see really deep symmetric T-wave inversions on this picture, and then we see a biphasic T-wave. It first goes up and then comes down. And these are both examples of the Wellens pattern. This is Wellens type A with the biphasic T-wave, and this is Wellens type B with the deep symmetric T-wave inversion in the precordial leads. And this is not suggestive of an acute plaque rupture event, but it is suggestive of dynamic platelet aggregation inside the LAD, which could develop and eventually lead to a complete occlusion. So these patients need to be watched very closely. In this case, we see in lead V3, but we can imagine that this continues in most of the precordial leads. It starts with an ST depression and then progresses up into a really tall symmetric T wave. And this is called De Winter's pattern, and it's also suggestive of a proximal LAD occlusion that should be treated generally with urgent invasive intervention. Another pattern that you really have to recognize, if you see in leads V1 and V2 tall R waves without a clear S wave, and ST depressions and an upright T wave, that's often very highly suggestive of a posterior MI. And some cardiologists and ECG books recommend that you analyze this by flipping the ECG upside down, in which case you'll see that this tall R wave becomes a Q wave, and the ST depression becomes an ST elevation, and this T wave here, instead of being upright, it becomes inverted. And so you'll see a pattern that looks like this, which, if you saw in any other lead, would be very concerning for an acute MI. Finally, we see a pattern that is often missed. So this is an ECG where, again, there's no ST elevations, but we see ST depressions in pretty much every lead. V6, V5, V4, V3, V2 a little bit, and in leads 2, AVF, AVL, and 1. So we see at least 9 leads where there's significant ST depressions, and the only ST elevation you'll see here is in a lead that we don't often look at, AVR. Whenever you see something like this, diffuse ST depressions with only ST elevation at AVR, this should really scare you, because this can be a pattern associated with a blockage in the left main coronary artery, or it can be indicative of triple vessel disease, and either of those conditions are very serious, very life-threatening, and require urgent intervention. A common question that comes up is, what do we do about a patient who has a bundle branch block on their ECG, or they have a pacemaker in place? How do I know if they're having an acute MI based on their ECG? So commonly, many people were taught that a new left bundle, or if you're not sure whether it's a new or old left bundle, you should automatically treat that as what's called a STEMI equivalent and call cardiology for catheterization right away. But the newest guidelines from the American College of Cardiology actually don't recommend treating a new left bundle in isolation as such, assuming that the patient's hemodynamically stable. And one of the major reasons for this is that the blood supply to the left bundle is fairly robust, so you're going to need quite a significant area of the myocardial wall to be affected before you're going to get a new left bundle that will be caused just by ischemia alone. So if you have a patient with stable vital signs doing fairly okay, that left bundle that you see on the ECG is much less worrying. On the other hand, a new right bundle branch block can be very worrying. Now, often the reason that people don't automatically worry about a right bundle branch block as much as they used to about a left bundle is that there's many other things besides structural heart disease that would cause a right bundle branch block, most notably a pulmonary embolism. And new right bundle is actually one of the signs we'd look for in an ECG to suspect a pulmonary embolism. But in the setting of someone who comes in with chest pain, typical chest pain and shortness of breath, with multiple coronary artery disease risk factors, a new right bundle is very worrying because it can suggest that the proximal portion of the LAD was affected, since the right bundle is supplied by one of the earliest branches of the LAD, the first septal perforator, S1. So how do we deal with patients who present with a left bundle on their ECG, or they have a pacemaker in place, and you want to know whether the patient ECG is concerning enough for invasive intervention? So what we can do is apply the modified Scarbosa criteria, and you should be concerned if any of the following criteria are met. One would be an ST elevation of at least 1 millimeter in any lead with a positive QRS. That's usually the lateral leads, like 1 AVL, V5, and V6. If you see any ST elevations there, you should be worried. If you see an ST depression in leads V1 through V3, you should also be concerned because those leads in a left bundle or a pacer tend to have ST elevations rather than depressions. Finally, the third criteria is that if you see ST elevations in V1 through 3 that are disproportionate to the size of the corresponding QRS complex, in other words, greater than 20% of the corresponding S wave and absolutely greater than 2 millimeters, you should also be concerned. Here's an example of a patient who presented with typical chest pain, and this ECG was obtained. Here you see ST elevations in leads 2, 3, and AVF, which are automatically suggestive of an inferior wall infarct. In those same leads, you see prominent Q waves, which suggests that this infarct might have been a little older, maybe several hours to days old. In addition, we see tall R waves in V1 and V2 associated and along with ST depressions, which, as I said before, is suggestive of posterior wall involvement as well. So here we're dealing with a subacute posterior and inferior wall infarct. Notice that this is also associated with bradycardia. The heart rate in this patient is unusually slow, which reflects the fact that the culprit vessel here is likely the right coronary artery. And as I said before, the right coronary artery does supply the SA node, which is why the patient is bradycardic. Here's another common example you'll see. In this case, you see very, very prominent ST elevations in leads V2, V3, V4, and V5, which is typical for involvement of the LV apex. Sometimes it's also called an anterolateral MI, although in general the location of the wall that would be affected would be the apex. The specific shape of the ST depressions, their ST elevations, they're concave down and sometimes described as having a tombstone shape, which reflects how serious these ST elevations are, particularly as they're likely involving the LAD artery. Also, we're seeing very prominent Q waves in all of the same leads, which again tells us that this is a subacute infarct involving the LAD. Now, when seeing patients who present with chest pain and you suspect of having ischemic heart disease, there's a few things to keep in mind. First is trying to classify exactly what kind of chest pain they have. And we talk about patients who have typical, atypical, and non-cardiac chest pain. Typical chest pain has the following features. It's usually described as a crushing or pressure-like midsternal chest pain. It's exacerbated by exertion and alleviated by rest or nitrates. Patients who have all three of these features associated with their chest pain are said to have typical chest pain. Patients who have just 2 out of those 3 features are said to have atypical chest pain, and patients who just have 1 or none of those features are said to have non-anginal or non-cardiac chest pain. Other features that point you away from a diagnosis of ischemic heart disease would be chest pain that's pleuritic or worsened by deep inspiration, chest pain that's worsened when you directly palpate the patient's chest, pain associated with eating, which might suggest a GI-related diagnosis, or positional chest pain, which can sometimes point to pericarditis. This table, which was taken from the European Society of Cardiology guidelines, explains how you can put that information together with the patient's age to give you a pretest probability that the patient actually has ischemic heart disease. And what's nice about this table is they color-coded it, so you see patients with a pretest probability less than 15, which include women less than 60 years of age who present with atypical or non-anginal chest pain, are very unlikely to have anything acute cardiac going on. So patients who present with this usually are discharged or just given a brief period of observation in the hospital. Usually they get most of their diagnostic work done as an outpatient. whereas the patients in pink and red, which especially men greater than 40 years of age who present with typical chest pain, they almost certainly have active coronary disease going on, and they should definitely be admitted for further testing. So moving on, we can use some of these criteria to help us figure out how to triage our patients with suspected chest pain. And we do this by grouping them into one of several categories. Firstly, if the patient had any of those ST elevations or concerning ECG features that are not ST elevations, and those are not explained by alternative diagnoses such as hyperkalemia or a bundle branch block, you'll need to involve cardiology as soon as possible for them to do invasive intervention such as PCI. So those patients will definitely not be admitted to the floor right away. On the other hand, if you have patients who do have worsening symptoms of chest pain or meet the criteria for an MI with troponin elevation, but they don't have any of those concerning ECG features that would warrant invasive intervention right away, you'd label them as either unstable angina if they didn't meet the criteria for an MI, or non-occlusive MI or non-STEMI if they did meet the criteria for an MI. And these patients will certainly be admitted from the ED. Patients who do have ongoing typical chest pain that doesn't seem to be getting any worse over the past few days, and they don't have any of those concerning ECG findings, they're labeled as stable angina. And finally, we have the patients who present with atypical chest pain. They have much lower pretest probability. Those would be mostly your patients in that blue category on the previous chart. They're your patients who come in as we say, as ACS rule-outs. We admit them for monitoring of their troponin and just clinical symptoms to see if they're demonstrating features of a myocardial infarction later on. One of the really useful tools that we use for clinically assessing a patient's risk of having MI, in addition to that chart I showed you before, is the HEART score. And the HEART score is an acronym for 5 different clinical features that you would look at to calculate the patient's risk. The H stands for history, so you can look at whether they have typical, atypical, or non-anginal chest pain. E is for the ECG changes, whether they have localized ST depressions, non-specific ST changes, or including T-wave inversions, or no ST changes at all. Any patients with ST elevations that are concerning shouldn't be getting triaged using the HEART score. They should be going straight to cardiology for possible PCI. A is for age. R is for risk factors such as hypertension, diabetes, hyperlipidemia, smoking, and family history of MI. And T is for the troponin. So for each of these 5 categories, they'll be assigned a score of 0 to 2 for a total score between 0 and 10. And any patients who score 4 or more should be admitted to the hospital to cardiac telemetry for further monitoring and evaluation. Moving on to medical management, for stable angina, the patients who you're going to triage to admission should get the following intervention. Start them on aspirin 81 milligrams daily if they're not already taking it and they don't have any contraindications. Start a beta blocker, preferably metoprolol tartrate or carvedilol. Start a high-intensity statin, such as rosuvastatin 20 milligrams to 40 milligrams. And you can optimize their anti-anginal therapy. And some of the options for additional anti-anginal therapy would include a non-dihydropyridine calcium channel blocker, a dihydropyridine calcium channel blocker, such as amlodipine or nifedipine, a long-acting nitrate, such as isosorbide mononitrate. And when all of these other things have been added and still the patient's having anginal chest pain, you can add the last line agent of ranolazine, which is a sodium and potassium channel blocker, and it's only contraindicated in those patients with elevated LFTs and QT prolongation. In addition, these patients should be getting serial troponin levels and ECGs to look for dynamic changes that would warrant you to step up the therapy and potentially take them for catheterization. Order a transthoracic echo to look at their ejection fraction and look for wall motion abnormalities. And order an appropriate stress test as necessary. So, when you order a stress test, it's important to understand what you're really ordering and when you should order a specific stress test given a patient's specific condition. So the purpose of a stress test is to look for evidence of reversible myocardial ischemia that you could potentially correct by doing a PCI or CABG or some other intervention. If a patient has evidence of irreversible injury or infarct, then revascularization isn't really going to help them, in which case only medical management would be indicated. The idea behind a stress test is that you're going to give some intervention or agent that will put some stress on the heart, and then you're going to look at the effect of that stress or agent on the heart. So some of the stress agents that you can use are just to have the patient exercise. If they can't exercise, you can use pharmaceutical agents such as dobutamine, which is a beta agonist, or a coronary vasodilator such as adenosine or regadenoson. And the way these coronary vasodilators work is that, let's say you have two coronary vessels, one of them blocked by atherosclerosis. The normal response of the heart would be to vasodilate this artery as much as possible in order to stretch it out and create an opening enough for blood to flow properly. And so blood would be shunted preferably away from the healthier artery towards the less healthy artery so that it can overcome this obstruction. Now, by giving a coronary vasodilator, you're dilating all the arteries equally. So you're also dilating the healthy artery, in which case this blood, extra blood that was getting shunted towards the diseased artery is going to go back down the healthy artery, and that's going to pull blood away from the diseased artery and bring out the ischemia that's underlying as a result of this blockage. Next, after stressing the patient, you have to do some kind of test in order to identify whether there's evidence of ischemia. And you can do that by getting ECG before and after the stress. You can do an echocardiogram before and after the stress, or you can do a nuclear medicine test called myocardial perfusion imaging, which looks for the heart's ability to take up a radioactive isotope. And ischemic or infarcted tissue will be significantly worse at taking up that isotope. So in order to choose the right stress test for your patient, you need to know their exercise capacity as well as whether they have any specific contraindications to certain imaging modalities or pharmaceutical agents. If a patient is able to run on a treadmill, they don't have any leg ulcers, amputations, severe claudication, and they also don't have any baseline ST depressions, a baseline left bundle, paced rhythm, severe left ventricular hypertrophy, using digoxin or an accessory pathway with Wolff-Parkinson-White syndrome. If they don't have any of those things, you can stress them using just a plain old exercise ECG with or without an echocardiogram. If a patient can exercise, but they do have ST depressions, LVH, digoxin use, or Wolff-Parkinson-White syndrome, but not LVH or not a left bundle branch block, rather, or a paced rhythm, you can use exercise myocardial perfusion imaging. You can't use the ECG because those conditions will interfere with the ECG interpretation. If the patient can't exercise for several reasons, you have the option of choosing a pharmaceutical stress test, and you'll have to pay close attention to the patient's other comorbidities to decide which pharmaceutical agent you're going to use. You shouldn't use a dobutamine as your stress agent in any patient with a tachyarrhythmia or severe uncontrolled hypertension, because dobutamine can worsen those conditions. And you should not be using coronary vasodilators like adenosine in patients with bronchospasm, because it can worsen that, and AV blocks, because it's a very powerful AV blocking agent. So patients with either a left bundle branch block or pacemaker, the only option for those patients would be a pharmaceutical nuclear myocardial perfusion test. Moving on to the management of patients with unstable angina and non-occlusive MIs or NSTEMIs. Again, you're going to be admitting these patients this time for much closer monitoring. You'll also be obtaining serial ECGs and troponins to look for changes. But in these patients, you're going to want to start them on a full regimen of medical therapy. You'll calculate the TIMI score, thrombolysis in myocardial infarction, and you can use this to help guide the timing of potential intervention. If they have a TIMI score greater than 3, they may need more urgent intervention within 48 hours. Or if they don't have a particularly high TIMI score, you might just manage them medically and see how they do with that. First step in medical therapy is giving them high-dose aspirin, 325 milligrams crushed once, followed by 81 milligrams daily. You're going to want to add a second antiplatelet agent, which can either be clopidogrel or ticagrelor. Both of them you're going to load with a high dose, then continue with a lower daily dose. And the reason you need 2 antiplatelet agents, if possible, is because of the huge role that we saw of platelet aggregation. If this is a atherosclerotic plaque, the aggregation of little platelets on top of this plaque are what can lead to worsening thrombus formation and eventually occlusion. So you want to prevent that by giving 2 different antiplatelet agents. In addition to the antiplatelets, one of the biggest risks is if the plaque ruptures, you'll get a complete thrombus formation. And to prevent that, you're going to give them an anticoagulant, preferably heparin, which can be easily titrated. Many cardiologists suggest continuing the heparin for 48 hours. And this is a relatively good idea in patients who have a high bleeding risk or don't have or whose symptoms improve after the initial heparin infusion. But in other patients, you'll want to continue this either until they get intervention with PCI or until discharge. You should also start a beta blocker on these patients if they don't have any contraindications. Again, a high-intensity statin. You should be obtaining an echocardiogram to look for wall motion abnormalities. But if the patient is not stable, you shouldn't be ordering any stress test until their symptoms improve. So unstable angina and STEMI, they're both reasons to delay doing a stress test because the stress test can actually worsen their condition. And be sure to evaluate the patient for any potential active bleeding before starting a patient on a regimen of dual antiplatelets and anticoagulation. In the past, even as a medical student, I was taught that the treatment for myocardial infarction should include morphine, oxygen, nitroglycerin, and aspirin. They had this acronym of MONA. But we later found out that apart from aspirin, none of these other interventions actually have any mortality benefit, and they may actually cause harm. So morphine, it will help with the patient's pain, but in many cases we actually don't want to mask their pain because worsening pain is actually a sign that things are getting worse as far as their coronary vessels are concerned, and they may need intervention faster than normal. So we want to actually know if their pain is getting worse. So give them enough pain medication to take some of the edge off, but not to completely mask it. Oxygen, not every patient who comes in with an MI needs oxygen. So oxygen in the setting of ischemia can actually lead to free radical injury from reperfusion injury, and you should only give this to patients who are actually hypoxic. Nitrates is another big one. So nitrates can, again, help with the pain, but if you're not sure whether the patient has right ventricular involvement with the infarction, or if they potentially have taken any erectile dysfunction medications in the recent few days before coming in for their myocardial infarction, the administration of nitrates can actually acutely lower the right ventricular preload and cause them to become very hypotensive, which is definitely not something you want in the setting of an infarction. So going back to our patients who actually do have significant occlusive myocardial infarctions or STEMIs, what can we do to help them out? So first of all, they need acute urgent intervention of some sort. Preferably, they will get something called Percutaneous Intervention, or PCI. That's the first line intervention that's recommended. And any patient who presents to a PCI-capable facility should be getting PCI within 90 minutes of arrival. That's the door-to-balloon time that's often quoted. If a PCI is done and certain findings are noticed that cannot be addressed with the PCI alone, and that includes greater than 50% occlusion in the left main coronary artery, greater than 70% occlusion in 3 different vessels, such as the LAD, left circumflex, and RCA, or if they have any complex anatomy that cannot simply be stented open, they're going to get open heart surgery with coronary artery bypass graft, or CABG. Finally, patients who present to a non-PCI capable facility, often in rural areas, and they can't be transferred to a PCI facility within an hour, they'll get thrombolytic agents such as alteplase or TPA, tenecteplase or TNK TPA, or retiplase. And in modern medicine, this is really a last resort option when none of the other strategies are available. So let's go into detail on all of these 3 interventions. First, PCI. The way PCI works is a catheter would be placed in either the femoral or radial artery and threaded up to the heart. They'll inject contrast through that catheter and in order to visualize the coronary anatomy and look for the blockage. Now, this is not a benign procedure by any means. Some complications would include causing an arrhythmia from irritating the myocardial wall. You can cause hemorrhage, especially since during the procedure the patient will be injected with anticoagulation throughout in order to prevent clot formation. And a very common complication in patients with severe atherosclerosis is you can dislodge a plaque from the arteries and shower it into the systemic circulation, causing cholesterol embolization. Here's a diagram of how this all works. So this patient had a arterial catheter placed in the femoral artery, which was threaded up through the aorta, up the aortic arch, and into one of the ostia, into the coronary vessels. Contrast was injected through this catheter, and the blood vessels will light up with the contrast. Now, because you are using quite a bit of contrast, one of the major concerns of PCI is always causing nephrotoxicity or renal failure. And many patients who already present with acute kidney injury, interventional cardiologists would often prefer to wait until the kidney function improves before proceeding with the PCI, as they can potentially be sent into ESRD and require dialysis. Once the catheter is in place, what an interventionalist can do is perform angioplasty and stenting to relieve the occlusion. Some of the stents that we use, the most common are the drug-eluting stents, and these are stents that are coated with a chemotherapy agent. And that chemotherapy agent prevents endothelialization or cellular formation on top of the stent. And the benefit of preventing endothelialization is that new cholesterol plaques are unable to form on top of that stent, and so it should hold open the vessel for longer. The downside is that because that exposed metal on the drug-eluting stent is a foreign body, it's a prime target for platelets to form and potentially create a thrombus there. So in order to prevent that, patients who get drug-eluting stents require long-term antiplatelet therapy, preferably at least a year, although it can be shorter in patients who have severe bleeding risks. On the other hand, bare metal stents, which aren't used quite as frequently, they endothelialize quickly because they're not coated with any chemotherapy agent. The benefit is that patients don't need to be on dual antiplatelet therapy for quite as long, only a month. But these stents do carry a higher risk of restenosis, so in general, interventionalists do prefer the drug-eluting stents. Here's a diagram of how that works. So the black area represents an area of occlusion inside of the coronary vessel. The catheter is threaded through that occlusion, and around it is wrapped a balloon and the undeployed stent. So when the catheter is in the right place, the interventionalist will inflate the balloon, opening up the blockage, and the stent will automatically attach to the vessel wall. And this will keep the vessel open and allow for free flow of blood through the vessel. CABG, like I discussed before, that's indicated when a patient underwent PCI and they found a 50% or more blockage in the left main, 70% or more stenosis in 3 vessels, or a complex anatomy that couldn't be easily stented. There's 2 kinds of grafts that are used in CABG. One is the left internal mammary artery graft, or LIMA, and they're used to bypass any LAD occlusions. They're really robust, and they can remain open for 10 years and even longer. The other option is a superficial vein graft, commonly a saphenous vein graft. So superficial veins from the patient are harvested, and they're attached to the coronary vessels to bypass their area of blockage. And because these are venous grafts, they're not quite as robust, they won't last quite as long, and they also contain valves, so the graft has to be inserted in the proper direction to ensure that blood is able to flow. Here's a diagram of how that looks. So here's a LIMA graft coming directly from the aortic, which is coming off the left subclavian artery, and it's coming all the way down and attaching onto the LAD just after an area of blockage right here. So a LIMA graft bypassing an LAD occlusion, very robust graft here. This, on the other hand, is a venous graft, which is why it's colored in blue. It's starting from the aortic arch, and it's bypassing an area of blockage in the right coronary artery over here. Finally, it's very important for any internist to recognize some of the common complications of MI, how to recognize them, and how to treat them. So in the early days following an myocardial infarction, one of the most fatal events that can occur is an arrhythmia, especially ventricular tachycardia or ventricular fibrillation. You'll recognize that when the patient starts having palpitations or syncope, or you start seeing runs of VT occurring on a telemetry monitor. This is why patients who do receive intervention are placed in an ICU setting for the period immediately after the MI to specifically look for runs of VT or VF and address them right away. The preferred agent for treating VT in the setting of an acute MI is actually lidocaine. This is one of the few situations where we do prefer lidocaine as a first-line agent, but amiodarone is also an acceptable option. Additionally, in the early phase after an MI, a patient can develop early post-infarct pericarditis. They'll usually present with pleuritic chest pain, and in ECG will show ST elevations and PR depressions, as we saw before. The treatment in this variant of pericarditis is high-dose aspirin rather than any other NSAID, because in the acute period after an MI, aspirin is relatively safe, whereas other NSAIDs can worsen the patient's condition. In the subacute period of 2 to 7 days following an infarct, the myocardium that's damaged is at its weakest, and it's prone to completely rupturing and causing 3 really serious complications that you have to be able to recognize. If the left free wall of the myocardium is ruptured, usually you'll see this in a lateral MI, you can get spilling of the blood into the pericardial sac, causing cardiac tamponade. And these patients will present in acute obstructive shock, and you'll want to obtain an echocardiogram on these patients right away. You're going to be looking for a large pericardial effusion with collapse of the RV during diastole. That's pretty specific for severe tamponade. And on vital signs, you'll see pulsus paradoxus, which is a dramatic decrease in the patient's blood pressure on inspiration. If instead of the left free wall, the inferior wall of the LV is affected, that can lead to the papillary muscles that connect to the mitral valve rupturing, and that'll lead to acute mitral regurgitation. And these patients are going to present with acute onset of shortness of breath, acute heart failure symptoms. You'll also obtain an echocardiogram on these patients, and it'll show severe mitral regurgitation. If you did a right heart cath on these patients, which is often connected to these patients in some institutions, you'll see on the pulmonary capillary wedge pressure tracing prominent V waves, which is a very clear finding of acute regurgitation. For these patients, they're going to need a rapid afterload reduction with nitroprusside drip and possibly place an intra-aortic balloon pump. The only definitive treatment for this is surgical repair of the valves. Finally, if the septal wall is involved and that ruptures, it can lead to an acute ventricular septal defect. These patients will also present with acute onset of shortness of breath. If they have a right heart catheter in place, you'll see an unusual step up in the oxygenation, the saturation, from the RA to the RV, because oxygenated blood from the LV is flowing into the RV. These patients also need acute afterload reduction with nitroprusside drip and intra-aortic balloon pump, and again, the only definitive treatment is surgery. In general, all of these rupture complications, tamponade, regurgitation, and VSD carry a very high mortality risk, and many of these patients actually don't make it for surgery. In the several weeks, 2 to 4 weeks following an MI, there is a different set of complications that you'll see. One is an LV aneurysm. This is when there's an outpouching of the portion of the left ventricle through weakened fibrotic areas in the myocardium. They usually don't present with any symptoms as a result of this, but on their ECG, you will see persistent ST elevations. And if you did an echocardiogram, you would be able to see that aneurysm in the LV wall. So patients who present with persistent ST elevations despite their chest pain having resolved several weeks after they had an MI, you should suspect they have an aneurysm. The biggest complication of an aneurysm is that the blood or in that aneurysm space is more static, so there's a tendency to form clots, and some of these patients may need to be long-term anticoagulation to prevent strokes. Finally, there's a complication called Dressler syndrome. which is also a form of pericarditis, but instead of occurring early within the first few days, this is a little more delayed, occurs after several weeks after the MI. They'll present with typical pericarditis symptoms, fever, leukocytosis, and pleuritic chest pain. Again, you'll see ST elevations and PR depressions on the ECG. And the treatment in this case, as long as the patient is 4 weeks past the MI stage, it's okay to give a strong NSAID like indomethacin. That's all for today's lecture on ischemic heart disease. Thank you for listening and have a good day.